ممكن أعمل ميوت صح؟ ميوت ممكن أعمل ميوت صح؟ جيب الهاند فري بس
الرحيم.
أهو
أنا
أهو.
يا ربي
بس أنا مش عارفة الصوت عالي ولا مش عالي. أنا كده أعمل ميوت صح؟
السلام عليكم. I hope that the sounds okay. I'm just sharing the screen. Maybe someone need to mute himself because I try to mute him, but he maybe he's so. Yes, we just reviewing the cases today in musculoskeletal module, and our target to focus in the exam tips and try to show you if there is any experiences that can help, can be useful. So let's take some cases in a short way. As we know, the EDIR, it have the 3 parts. MRQ part, which is similar to the FRCR part 2A, which have just MCQ. And the second part is the short questions. We try to show you some examples in every session. And this short questions is like, he can ask you in anatomy, he can just show you like one image and try to ask you about the differential diagnosis. And we try to show you in the previous session this type of questions. The last part, which is the most important part, is the long question, which have like one case, but he show you like many series of images, and probably he start with something simple, for example, like X-ray, and he go more advanced with you, and all are screen and computer-based exam. So let's start our can be enjoyable for us. So this case, I think one of the spotting case that everyone should be aware of it. If I try to make some unmute for some people, but already I make mute for all. So if any want to talk, just he can unmute himself, okay? So, or you can just show in the chat as we do every time. Okay. So what do you think about this? Because it's like a spotting case, and yes, exactly. This is like posterior shoulder dislocation, which is light pulp sign. Sometimes it's hard to be distinct, but in this case is very obvious that you can see it well. Also, if you see this Y-shaped view, is important to visualize that the coracoid process is anterior in the anatomical landmark, and the acromion and the scapula spine is posterior. So if you see the humeral head in this posterior location, it should be in the middle here. So if it is in posterior location, this means that, so some of us may be familiar with the light pulp sign here, but some of us is not familiar with this. So this is very important to recognize it in the Y position, okay, Y view, okay. This maybe it will be the axial view, and which is the most easier one. So you can see again the dislocation, which is the posterior. So which one is more common, the anterior dislocation or the posterior dislocation in the shoulder? Which one is the more common, which is the MCQ question? The anterior, exactly. More than 90% of cases is anterior shoulder dislocation, yes. And there is some sign that you should be aware of them, and they like it in the exam, and you maybe you like it also, trough sign, rim sign, absent crescent sign. So you have many signs that one of the important things that you should know that association or complication, which is reverse hillside, hill sac, and reverse Pankert. So if this patient underwent MRI, you will search for reverse Hill-Sachs or reverse Pankert. So, or maybe if there is any affection of the periosteum and further Pankert lesions. Okay, so this is the anterior dislocation. Again, in the position, you can see that the humeral head changed its position either in the axial view or in the, so this is more easier. And with this one is associated the Hill-Sachs or the Pankert. Okay. So I think this one, it is in the pelvis, and you can see in the X-ray pelvis after you make your checklist that you can recognize, yes, that there is something going in the bone or joints or in the soft tissue. Yes, there is fracture here, exactly. So when you find the fracture, you should search for other fractures, right? So if you find that there's maybe something going here with some diastasis, yes, right, perfect. But again, you shouldn't be satisfied because there is something going more. Yes, maybe, but we cannot see impingement. We can see dislocation, exactly, yes. So there is bilateral hip dislocation. You can see that the femoral heads on both sides are changed in position. So the acetabulum is here. So you can see that it is changed upward, right? So which type in the pelvis is more common? Is it the anterior dislocation or the posterior dislocation? This is another MCQ question. The posterior, exactly. So the pelvis or the hip joints is in the reverse of the shoulder. The more common here is the posterior dislocation. And when you find this, you should search for fracture either in the anterior column or in the posterior column. So you should search for other fractures, and you should search also for any complications, exactly. So another CT for the same patient, and he show you that how it can be looking with this bone fragments. Okay, so the posterior the most important. So we can shift to another type of questions. In this case, maybe can come to you the short case and he ask you what could be the spotting or antimony case, or maybe if you can put a differential, exactly. So this is like a Paget disease, which is the blade of grass, exactly sign. You can see this lytic area, which come in the long bone. So long lesion in a long bone could be differential, but here with this appearance with blade of grass, you can just think in Paget. And if it is in lytic phase, if he did bone scan, it can look with hot appearance, right? Yes. As we know, the Paget disease can come either in lytic or in sclerotic or in mixed type. So we have here like a sclerotic. Fibrous dysplasia will come to us, and we can put differential diagnosis, but with this appearance is like a characteristic to be Paget disease. Also, fibrous dysplasia, the key of it can be the age. I mean, if the old age, you can think about that is a Paget. But if it is, if he's young or she is young, so you can think about. Also, check here that there is cortical and trabeculation, which is more with the Paget disease. Okay. So Paget blade of grass, if it's come the skull, which is called osteoporosis circumscripta, and here you know about the types, and there is some complication to be sarcomatous degeneration in some people. So this is one in the osteoporosis circumscripta, yes. And you can see here in the bone scan that can have hot appearance or yes. Another appearance of Paget, if you are lucky, you can see this scoton wall. I don't know if someone see in his life this or not, but yes, can come to you. Paget disease again. Can you tell me what is this arrows denote for in Paget disease? Because it is an important sign that to recognize it. This arrows, what? Yes. So this very nice answer. Yes, this is thickening of iliopectineal line, and yes, yeah. So when you find these two lines and they are thickened, this is the key that you can think about Paget. So Paget with this thickening is the key. Can make some enlargement, but here this trabeculation and this thickening, you can get the key that it is Paget, especially if this patient is an old age. Also here you can recognize something going here, yes. That maybe something happened, yeah, as a fracture, yes, okay. So another type of questions about Paget that he can give you this type of vertebra, which is frame vertebra sign, and which is spotting case for Paget, yes. Another type which is very tricky because you can mention that it can be metastasis, and if you remember, you can put lymphoma, as we know that metastasis and lymphoma can give both this appearance, but don't forget that can also from infection or Paget disease. So ivory vertebra differential diagnosis is one of the most important in your exam, whatever MCQ, short or long. Okay. Another, when it is active in the bone scan, it can give you this appearance. Note that there is some thickening and some enlargement, which is characteristic for Paget. Yes. So let's shift to another question, which is hand X-ray, and you are searching for, but which category? I mean, before you get to the diagnosis, why you say that this could be scleroderma? Because you see, is it a bone disease or joint disease or soft tissue disease? Yeah, there is something going with the terminal phalanges, yes, which is soft tissue or bone, yeah. Yeah, or joint. So it is more with soft tissue, right? Yeah, with some acrosteolysis. So this is the key when you find this soft tissue calcification, and there is also maybe some atrophy, yes, and subcutaneous calcification, or maybe sometimes you can get something in the joint, but he's not clear. But you can see that the soft tissue calcification with acrosteolysis is the key that can guide you to think about scleroderma. Yes. Also, the prediction for scleroderma to be in the terminal, like in the DIB, distal interphalangeal joint. So yes, I agree with you. So let's go and see another appearance. Here with you can see the soft tissue, sorry, the joint calcification with the soft tissue calcification also. But yeah, exactly. So one of the commonest to do atrophy with acrosteolysis and calcification and some erosions sometimes, yes. So here when you mention that there is soft tissue calcification, the next question probably will be the differential of soft tissue calcifications, what it could be. So one of the giant important exam tips or exam titles that you should put in your mind, hyperparathyroidism. I think it's like one of, if you go in musculoskeletal, you should have like big titles. And this one of the big titles, the hyperpara. Okay. So hyperpara, scleroderma, and maybe you can include perms, systemic lupus, and dermatomyositis. Yes. So don't forget this because it's important. Also, scleroderma will give you another differential with the acrosteolysis, which you can save this word, okay, and try to memorize with psoriasis, bichinodysostosis, any injury, neuropathy, which is the diabetes, and leprosy, collagen vascular disease, again hyperpara, some congenital and some familial, and finally something maybe, yeah, okay. So this is one of the important differential. Let's go to another one. Yeah. So exactly. So when you see this again, the giant title in the MCQ MSK book, that you find salt paper skull that guide you to hyperpara, yes, and probably if you are lucky to get another picture of lytic lesion present in, for example, this long bone, so you can think about crown tumor, exactly, yes, and yes, and yes, Roger-Jersey spine, perfect, which will guide you to be the hyperbara. Yeah. And here, if you find also something maybe can be helpful, we mentioned crown tumors, yes, erosion, exactly, erosion of the clavicle, yes. So when you find the erosion, sometimes if the examiner is tough, he can start with clavicular erosions, then you mention the differential diagnosis, then hyperpara, then he show you one of the ski, which is easier, then you can know the diagnosis of hyperpara. So sometimes the clavicle is one of the important things to check, either the medial end or the lateral end. If you find any erosive changes, either medial or lateral, so check about it. So brown tumors, one of the important key for hyperpara. Sure that subariosteal resorption, especially the second and third radial aspect of middle phalanges, soft tissue calcification. So don't forget the differential of soft tissue and acrosteolysis. Sometimes it can give appearance that mimic erosions, and sometimes give you vascular erosions. Finally, this salt and paper, what we show you, okay, and yes, amyloidosis can be the complication, yes. So in this patient who have amyloid deposition, and finally he ended by pathological fracture. This sometimes come to you as differential to check the bone density and to give your differential, yes. And here another differential with soft tissue calcification, we mentioned it before. Then again hyperpara, when you find like a normal x-ray hand, then try to make some zooming and some try to use your tools to hardly reach the second and the third middle phalanges and check the radial aspects, that if you are lucky you can see some periosteal resorption, then you can call it hyperpara. It is not easy, but I think the guide will be also the history, yes. Again, another form of hyperpara, yes. You can see how it can come as acrosteolysis with soft tissue calcification. One of the important spots in the exam the loser zones, which is like pseudo fractures, or maybe you can consider it as an insufficiency fractures, and it is have this appearance. This one is very obvious. Sometimes it's not obvious like that. Again, this differential, when you find distal clavicle resorption, you will think about many differential, including rheumatoid and hyperpara and other differentials, including cleidocranial dysplasia, yes, MITS and lymphoma. It can be bilateral, so if it is bilateral, think about the giant three titles: rheumatoid, hyperpara, if it's young, or something congenital, cleidocranial dysplasia, right? So check the X-ray hand. If the examiner show you, or it is long question and he show you another image of X-ray, so maybe you get hyperpara. Roger-Gerse spine, we mentioned that hyperpara one of the differential, yes, but it differentiated from osteopetrosis, which is bone and bone or sandwich vertebra. It can differentiate it from Paget, which it have picture frame sign, yes, and also the vertebra is enlarged. Again, you will need X-ray hand. So let's have another giant title, yes. So I think that it's about to finish the first part. So we will go to the second, yeah, less than 1 minute. I see many differential now, erosive or psoriasis with seagull sign. So which one you are preferring? Yes, seagull wing sign, yeah, or erosive, yes.